Thank you very much, Agarwal sir and the Mumbai Hematology Group for giving the opportunity. So I'll be speaking on what is new in the chronic myeloid leukemia in 25th EHA Congress. So the topic of the discussion of the today is the leukemic stem cell, the TKI resistance, and which TKI and when, and what are the advances in the CML with the selected abstract from this the EHA. Move to the next slide. So there is the abstract book is there, and also the educational update in the hematology book in the EHA Congress. So the aspects of the CML, I will be trying to highlighting here. The educational update, there is the 3 lectures. The abstract, there is a 91 abstract is there in the oral abstract, the poster, and also the publication is there. But the majority of the things, there is a clinical abstract. The 2/3 is the clinical abstract in terms of the CML, and there is a 3 important lecture in the educational sessions. So in the education session, the current challenges in the chronic myeloid leukemia, there is the introductions and also the biology and the targeting the CML stem cell, and also the resistance of the TKI and the new treatment targets, and which TKI and when. Next. So in next slide, please. So in terms of the current challenges into the chronic myeloid leukemia, in terms of the role of the BCR-ABL, it is the diagnostic marker. We know that we can estimate the tumor burden, and also there is a therapeutic target is there in terms of the CML. And the current thing is that we are unable to cure the CML. Also there is a chance of the disease recurrence, because the 2 important thing is that there is survival of the leukemic stem cell, and also the mutation in the genes other than the BCR-ABL. In terms of the survival of the leukemic stem cell, there is a TKI related, and also there is a extracellular mechanism. In terms of the TKI related, there is intracellular signaling pathway, activation of the transcription, the epigenetic programming, and the inhibition of the apoptosis is there. And apart from that, there is the mutation of the genes other than the BCR-ABL is contributing for we are unable to cure the patient with CML. And also the development of the new targeted therapy, the BCR-ABL mutated or independent gene targeted is available nowadays. And basically we are trying to focusing on the personalized therapy in case of the CML. Next slide. So in terms of the CML is basically the stem cell is from the myeloid and the lymphoid lineage involvement. The clonal analysis, particularly the clone of origin, is the granulocyte, erythrocytes, platelet, and the myelocyte, monocyte. And also the leukemic stem cell, the phenotype, they have sometimes the normal hematopoietic stem cell phenotype is there. Next slide, please. So in terms of this, the quiescent stem cell, that is the very interesting slide is that in terms of the CML, BCR-ABL, there is direct evidence that the quiescent stem cell of the leukemic cell, they may be persist even after the treatment with the imatinib. Next slide, please. So in terms of this, the imatinib, that even after giving the long-term therapy with the imatinib, the people become resistant to the treatment with the TKI, because these the stem cell which are the BCR-ABL positive, and they are the quiescent in our bone marrow and becomes quiescent over the times. Next slide, please. So in terms of this treatment, if you analyze the beautiful paper, they have analyzed this that there is CD34 positive and the CD38 negative the stem cell. If you go across this the years, then there is a quiescent stem cell is become still persisting even after the long-term imatinib treatment. Next slide, please. So there is a potential mechanism of the persistence of the CML stem cell. Maybe the intrinsic and the extrinsic factor has become incorporating the survival of the stem cell, and there is some role of the microenvironment also in terms of this survival. Next, please. So in terms of this, the leukemic cell resistance, there is a diverse mechanism is there, and the important thing is that there is an interaction to each other of the environment, the TKI mutation, the signaling pathway, the mitochondrial mechanism, all becomes involving that leads to the leukemic stem cell resistance to the therapy of the recurrent TKI. Next slide, please. So in terms of this, the targeting the residual leukemic stem cell, if we targeted the residual leukemic stem cell, then we can cure the CML, means we can enhance the treatment for remission of the CML. And the important thing is that currently the limitation is that there is intolerance and there is a problem of the resistance, and ultimately down the line the people become relapse and become progress, and ultimately if we give continuous therapy there is a chance of final toxicity is there. Next slide please. So the TK resistance pattern is becomes usually heterogeneous. Next slide please. In terms of the resistance and the persistence, if you go to the resistance, means the responsible for the future achievement of the optimum response to the TKI and may represent the clinical emergence and also lead to progression to the blast phase. In terms of the persistence, there is a responsible low-level residual detection set is there, and this becomes responsible for the relapse, and that's what we call the stem cell resistance is there. So in terms of the resistance, in terms of the persistence of the disease, these are the major concern or obstacle for the curing the patient with CML. Next slide, please. So in terms of the targeting these things, so we can target the tissue, we can target the BCR-ABL pathway. Next slide, please. Then we can target the downstream pathway. Next slide, please. Then we can target the parallel pathway also. By way, we can targeting the CML in the down the line, and we try to improve the survival of the patient with CML. Next slide, please. So the resistance may be the complex, may be the multifactorial, but they are become an assemble of the different bricks. Next slide, please. So there is several mutation is there into the CML. We know, I'm not going into the details. Mutation may be the CLUB mutation, maybe the N-terminal, maybe the SH domain, all the things might be there. Next slide, please. So the kinase domain mutation is the interesting slide. If you do the Sanger sequencing, 25% mutation. If you do the NGs, there is 47%. And the mutation is also the increasing if there is a failure of the drugs. It is from the 47% vis-a-vis the 51% for the first line and the second line therapy failure of in case of the CML. Next slide, please. So in terms of this the kinase domain, it is basically ATP competitive inhibition, maybe the allosteric inhibition. Next slide, please. So in terms of the second generation, by giving the drugs, the nilotinib, usually the 4 hotspot mutation is there. Dasatinib also the 3 hotspot is there. Bosutinib, there is also 3 hotspot mutation is there. There becomes obstacle for the treatment remission. Next slide, please. In terms of this, the ponatinib, this is the drugs. The majority of the cases we are using the T315I mutation, but if you use the low doses, become interest to some mutation, particularly 255V. And also they may be developing the T315ML from the T315I mutation. So low dose may not be effective in the down the line. Next slide, please. But in terms of this allosteric inhibition, the assimilate, this is the new drug is become coming. There also the 4 to 5 hotspot mutation is there. We need to tackle them. Next slide, please. So in terms of the treatment of the CML down the line, so some in future, maybe the combination of the drugs becomes the more sensitive, and we can kill the TKI resistance mutation, and we can able to improve the survival of the patient with CML. Next slide, please. So in terms of this, the identify the genetic abnormality in the baseline, we can do the NGS, we can do the OS and the RNA sequencing technology. If you do the NGS technology, 30% somatic mutation, 15% pre-leukomic mutation, and if you do the RNA sequencing, there is 70% somatic mutation. We can identify also the copy number variation, also the new fusion gene we can identify in the baseline, and then we can predict that which group of the patients becomes going to bad, and the chance of progression to the BC will becomes high. Next slide, please. So in the down the line in the future, from identifying the genomic abnormality, we can identify the low, intermediate, and the high, and then we can tackle them by different intervention. In terms of the low level, we can give only imatinib, the second 2 genetic mutation, then we can do the second generation. If there is a level 3 mutation, then we can give the combination of the drug, or if the level 3 mutation, we can go ahead with the allogeneic stem cell transplantation. Next slide is. So the TK resistance and the CML is the major obstacle for the cure, and it is the poorly understood. Till now, the BCR-ABL kinase domain mutation is there. In future, the integrated clinical and the genomic-based risk stratification, I think, will be coming down the line, and sometimes the combination of the TKI with the different mode of action, I think possibly will be the down the line, and try to improving the patient with CML. Next slide, please. So in terms of the CML treatment, you know, the goal our nowadays is to prolong the survival, to prevent the disease progression, optimize the quality of the treatment of the given durable molecular response, and also the MR3 and the MR4.5 is the one of the important goal of the treatment with the CML. Next slide. So the further treatment with the CML, there is imatinib, dasatinib, nilotinib, and bosutinib all are available. The choose the selection of the TKI depending upon the comorbidity and also the side effect profile. Next slide, please. So in terms of this, the comorbidity, you know, if it is a cardiovascular problem, you don't use the nilotinib. If the patient has a blood problem, don't use the dasatinib. If the GI liver problem, don't use the bosutinib. Next slide, please. In terms of the algorithm for managing the CML have been discussed into this EHA that if we are the low risk, if you can start with the imatinib, if the patient develop resistance, we can switch to the second generation of the TKI. If again resistance, then we can switch to the alternative TKI. If we start with the second generation of the TKI, if the patient has a resistance or there is a mutation to T315I mutation, then we can directly go to the ponatinib and do the allogeneic transplant. So by this way, we can treat the patient with CML by sequentially using the drug. But nowadays, the second generation of the drugs is the drug of choice. You can use the treatment of the CML not only to the high risk, intermediate, and also the even low risk of the patient with the CML in terms of the MR4 and in terms of the early molecular response, deep molecular response that translate to the survival of the patient with the CML. Next, please. And also in this EHA, next slide, please. So also in the EHA, there is a few important landmark abstract has been coming, particularly the nilotinib that is called the ENAST pathway. This is basically the phase 3. This is the update of the trial. And I'm directly conclude this, the author conclusion that the overall there is around 72% has a MR4 in the 2 years down the line. Next slide, please, Kalpesh. So in terms of this, the decision trial, there is the decision cell, there is also the update data is there. There is a 3-year update data. And the 3-year update data, they have concluded that the 3 years follow-up, the response to the dasatinib remaining the higher with comparing to the imatinib with improving over the time. Next slide, please. So in terms of this, another, the bosutinib, the 8 years follow-up data have been also presented in this EHA. And the authors have been concluded that more than 8 years, the bosutinib continue to be the durable efficacy in terms of the MR3 and also the MR4 for the CML patient. Next slide, please. And the more interestingly is the asciminib. The asciminib is the heavily pretreated patient with pH positive CML and basically sensitive to the TKI. And this is the important drug. I think they have been used into the monotherapy in the relapse refractory setting, though this is the phase 1 study and they have been using the different doses. And authors have been concluded that the asciminib monotherapy become well tolerated and promising clinical activity in terms of BCR-ABL less than 1%. Next slide, please. So there is another interesting abstract in terms of this, the different dose ranging of the ponatinib. That is called the 45 mg, 30 mg, 15 mg. We know the ponatinib, there is a lot of the side effect in terms of the cardiovascular and the thrombotic event. So basically, hardly the people are continuing to the 45 mg. So this particular trial, they are addressing the 3 doses regimen in terms of the side effect and the efficacy. If we go to the MR value in terms of the 45, 30, and the 15 in the 1 year, there is a 14%, 17%, and also the 19.1%. And authors have been concluded that the trend towards the dose-dependent efficacy and the safety with the ponatinib. Next slide, please. So to conclude my talk, that we are unable to cure the CML or there is a chance of the disease recurrence due to the survival of the leukemic stem cell. And BCR-ABL plus stem cells become still persist even after long-term treatment with the CML. So we have to target the residual leukemic stem cell to improving the TFR or the cure of the patient with CML. And the resistance of the TKI usually the complex and the multifactorial. And we can identify the high-risk patient at the baseline. If we do the NGS at the baseline, so we can do the WS in the baseline, so the RNA-based sequencing, that we can diagnose the poor-risk patient and we can treat accordingly. And in future, I think the integrated clinical and the genomic-based risk stratification will guide us for the treatment selection to avoid the resistance and optimizing the outcome of patient with CML. Next slide, please. So, in the abstract, particularly the ENAST pathway study, the nilotinib, the 3 years, the MR4 is around 50%. In the description, the 3-year follow-up, there will be the MR4.5 is higher than the imatinib. The bosutinib, the 8 years follow-up data is the overall survival is around 75.4%. In terms of the asciminib, monotherapy becomes well tolerated and so promising clinical activity in terms of the pretreated patient with the Philadelphia positive CML. And the OPTIC trial, there is the dose ranging study of the ponatinib. This is the first interim analysis of this trial. They have clearly shown us that the ponatinib has a benefit and the risk profile related to the dose of this ponatinib. With this, thank you very much for the patient hearing. And if you want to access more, you can go to this abstract book of the EHA. Thank you very much. Over to the organizer, Agarwal sir.
Thank you, Dr. Tuphan. Couple of questions to you. As bosutinib has become available, where exactly will you recommend it to be used in India?
Bosutinib, sir, we can use in the frontline setting also, particularly if the patient has a lot of the comorbidity, the cardiovascular problem is there, the diabetes is there, the pleural problem is there. In the setting, I think the bosutinib will be the good drug of choice we can use in this setting.
The next question is, have you started using dasatinib 50 mg?
Recently, sir, paper has came. We started using. We have been given the 3 to 4% of the 50 mg. After this paper and after the several presentations from you and also the other group, we have been recently started the 50 mg dasatinib.